evening, good morning, good afternoon, from wherever everybody is. Welcome to our CyberSite webinar. The topic is management of complex forms of strabismus. We have two faculty, and the third is me, Dr. Andrea Molinari, Dr. Fiona Dean, and myself. We shall begin the topics with Dr. Andrea Molinari.
Well, hello to all participants of this webinar. Welcome, and today I'm going to talk on the surgical management in patients with congenital fibrosis of the extraocular muscles, which is probably one of the most challenging entities among strabismus syndromes. And this is mainly due to the profound anatomical changes that you will encounter in patients with this problem. Notice here a histological structure of the lateral muscle of one of my patients here on the left compared with the anatomical structure of a normal extraocular muscle on your right. You will see on the left only scarce muscle fibers, which correspond to this small pink structures here, immersed in this blue tissue, which corresponds to fibrosis formed by fibroblast and collagen fibers. On top of these important anatomical changes in many of the patients, you will find rare innervational anomalies like synergistic divergence here on your left, and convergence at elevation. You will see here on your left, the girl, when she tries to look to the right, the left eye not only does not adduct, but it does abduct. In the patients who show convergence at elevations, you will see that the patients, when trying to look up, both eyes converge. So all these anomalies, the anatomical anomalies and the innervational anomalies, make the surgical planning of these patients so difficult. And this will make that the results are so variable and unpredictable. The huge variability in the surgical results of these patients have been reported in several papers. And this is one of these papers where 9 patients were all treated with the same surgical technique, which was a free myectomy. And you will notice that in some patients, like case 6 to case 9, the effectiveness of this procedure was much larger than with the first cases. And this huge variability in the results of these patients has also been my experience. And I'm going to demonstrate this by showing 2 cases, my best case and my worst case. This was by far my best case. This was an 11-year-old boy that consulted due to this significant anomalous head posture, the chin-up posture, together with a severe ptosis and a very large exotropia. The patient could not elevate the eyes and also could not adduct the eyes. So during surgery, the forced duction test demonstrated a very significant restriction to elevation and adduction. In these patients, we elected to do bilateral 8 millimeters inferior rectus recession and bilateral 10 millimeters recession of lateral recti with a decent result, as you can see here. After this procedure, we performed a frontalis suspension, and the patient got rid of his anomalous head posture, and the eyes were pretty much aligned in primary position. It is important to note that when you are going to perform frontalis suspension in these patients that do not have good elevation, you have to be very conservative. You should try to place the lid not as usual at the limbus level, but on top of the pupil, because these patients do not have Bell's phenomenon, and the concern of exposure keratitis is really big. And here you can see the patient before the surgery and after only one strabismus surgery and one ptosis surgery, showing a pretty good result. Unfortunately, not all cases will respond in the same way. And let me show you my worst case. I saw this girl when she was 1 year old with a clinical scenario that was pretty similar to the previous one. She had a large exotropia, also a ptosis, not as severe as the previous case, and a very significant exotropia, also with restriction to elevation and to adduction. In this patient, we chose to perform a bilateral inferior rectus recession of 8 millimeters and bilateral recession of both, of lateral recti of 7 millimeters. And as you can see here in the postoperative picture, although the chin-up posture improved a little bit, the strabismus remained pretty much the same. So a couple of years later, we re-recessed both lateral recti 20 millimeters from the insertion with a hang-back suture. And you can see that the eye position did not improve very much. Finally, we performed a third procedure by resecting her left medial rectus 6 millimeters, which didn't do practically anything. So what to do next when you have a patient where you already did 3 procedures and the result is not good? And this might answer Dr. Al Nasser from Saudi Arabia's questions that he sent, what to do when you do maximal recessions of the muscles and you still don't get the result that you want. So I didn't give up with this patient, and a couple of years later, well, you can see here, no, after following this patient 9 years and 3 years after, her chin-up posture was better, but the eye position was pretty much the same. So I didn't give up with her, and we performed a 4th surgery. And we found, in this surgery, we found the left lateral rectus that was 18 millimeters from the limbus, not from the insertion, which meant that the previous recession that we performed with the hang-back sutures did not work as desired. The muscle crawled back. And we also performed a re-resection of the left medial rectus, fixating the globe to the medial periosteum with a Mercilline suture. And this is how the patient looked 5 years after the last surgery. The eyes were pretty much aligned in primary position, but she didn't get much movement in other positions of gaze. Surprisingly, even after fixing the lateral rectus to the periosteum, she could abduct the eye a little bit. So other thing to notice here is that we didn't need to do a ptosis surgery in this case. So which are the surgical techniques that we have in our armamentarium in order to treat patients with congenital fibrosis of the extraocular muscles? Some of them are more useful than others, in my opinion. We can perform a free tenotomy, a free myectomy, large recessions of the extraocular muscles, preferably with scleral fixation, not with hang-back sutures, since the muscle might crawl back. We're going to discuss the role of resections in these patients. And finally, we can use periosteal fixation in very severe cases. Periosteal fixation of lateral rectus is especially useful in those patients that show synergistic divergence, because in these cases, you really have to inactivate the force of the lateral rectus. And the best way to inactivate these muscles is through a periosteal fixation. So what about resections? Do they work? As you can see here, this is the medial rectus of the last patients that I show you. And you will recognize that the muscle is very thin. Notice how it is transparent to the hook, to the muscle hook, when you place the hook underneath it. So resections on these type of muscles, which are the antagonists of the fibrotic muscles, really don't work very well. Let me show you a surgery of one of these patients. This surgery is really difficult. It shouldn't be left in the hand of inexperienced surgeons. In most of the cases, you have to work very far back into the orbit because the muscle is so inelastic and fibrotic. And it's not only the muscle who is fibrotic. You can see that the tissues surrounding the muscles, the check ligaments, the intermuscular membrane, they are also very thick and fibrotic and contribute to this lack of movement that these patients having. Another characteristic that you can see here is how the vessels all over the muscle are really enlarged, which makes, and this is something you have to see, to take into account. Using grooved hooked muscles like this one is very useful in these cases in order to place the suture safely or to cut the muscle, as in this case. One other useful tip when doing a free tenotomy, like I'm going to do in this muscle, is when you have these large vessels, to cauterize the vessels first, because if you don't cauterize the vessels, they will keep bleeding. And you'll see here now that the muscle retracts far in the back of the orbit. And if they kept bleeding, it can produce a retrobulbar hemorrhage that will be very difficult to control. Another typical finding in these patients is the anomaly of the insertion. Here you can see here now after the tenotomy how the duction gets freed. But look at the diagonal insertion of the muscle. One border of the muscle is closer than the other one. This is also a very typical finding in these cases. So in the surgical treatment of congenital fibrosis of extraocular muscles, our goals should be to improve the anomalous head posture and to improve the ocular alignment, at least in primary position. You probably will not get much more in these cases. But even with such a fair result, you should try to help these patients, because even getting this result makes a huge difference for them. So to conclude, be prepared for unpredictable results in these cases. You have to explain the patient that you might need more than one procedure in order to get a better result, and explain them that they will never have a normal ocular motility. Large recessions, especially with fixed sutures, free tenotomies, and periosteal fixation in the most severe cases are, in my opinion, the most useful techniques to use in these type of strabismus. Always perform strabismus surgery first and then ptosis surgery only if required. Remember that these patients do not have Bell's phenomenon, and exposure keratitis is always a concern. Well, thank you very much for your kind attention today, and I will be very happy to entertain any questions.
At the present, there is one question on what do you mean by hangback? Is it adjustable? There's a question here asked.
Well, when you perform a hangback suture, the technique is very similar to an adjustable suture. The only difference is that you are going to adjust if the patient is cooperative. Most of these patients are children, so they are not very cooperative. So I usually do not perform adjustables. But I really stopped doing hangback in these patients because I saw that the muscles really crawl back.
I have a question. So since these questions are coming in, but still, but Andrea, would you prefer a straight away to go for a lateral periosteal fixation, like a tenotomy? Like what is the experience with tenotomy? I've never done a tenotomy.
Well, I do tenotomies, free tenotomies, in cases like the one I showed during my presentation, where the muscle is really tight, and it's very difficult to pass sutures and especially even more difficult to place the sutures very far back, that it is where you have to put them in order to get an effect or the effect you want. And what I have seen, which was shown in the video that I demonstrated, is that when you cut these muscles, they retract very far back in the orbit. And what you need here is just to free the deductions. And you get this by doing free tenotomies in these very, very fibrotic muscles. If I can, I prefer to recess the muscle by placing fixed sutures. But if this is dangerous because of the situation, I then perform just a free tenotomy.
Okay, so the one question is by Dr. Mohammed is the same thing, like hemi hang bag is preferable than hang bag. Means you take small bites on the sclera so that you have somewhere you have fixed it so that the muscle does not creep in. Yeah, so that's what another question is. Yes.
Yeah, I agree with that, and I have done hemi hang back, but you have to try to go as far back as possible to place the suture. And the other question was when I do the periosteal fixation. Well, I don't do the periosteal fixation as the first procedure. I do that when the other procedures failed, and like the second case I showed, and I do them in all the cases where I have synergistic divergence, because in these patients, you have to inactivate the lateral rectus.
So how much lateral rectus would you recess? The maximum you think we should recess in such cases? You just go as far back as possible.
Yeah, probably as far back as possible, or as far back where deductions get freed, when you see that deduction is negative.
Okay, because there's another question they've asked, is that Dr. Andrea, how to determine the length of the recession for inferior and lateral rectus in these cases?
Yeah, well, that's the answer. When you see that the forced action test is free. So what you can do is place it on a hangback suture, see when it's free, and then place a fixed suture where the muscle lies.
Yeah, so there's another question. How do you do the periosteal fixation? I think
Good, yeah. You know what, this morning I was thinking, since I had a couple of minutes left, I should have added a video on how I do the periosteal fixation, because actually for strabismus surgeons, it's not an easy procedure to do. So I find it very, if we have time, I will try to find it in my computer, and at the end, maybe I can show the technique. Yeah, what I use is a baby right ptosis needle, and I do a small cut at the periosteum over the skin here, and then I disinsert the muscle, and I pass this ptosis needle, and I take it out through the skin suture, and I pass the needle, which is very strand, the needle through the periosteum at the orbital rim. And then you make the knot outside the skin, and it's a very small skin, just 2-3 millimeters, a very small wound in the skin, just 2-3 millimeters. So it doesn't get noticed afterwards. And this is the easiest way I find to do a periosteal fixation of the lateral rectus, of course.
There are more questions coming in, and we'll just take one more. Okay. Hi, Dr. Andrea. It's from Dr. Wei Yuang. I hope I pronounced it properly. I'm so sorry. How would you decide which procedure to choose when the patient was initially seen in the clinic, or the decision is made intraoperatively? Would you do which helps in
how I decide? If I have a patient that has a large exotropia, a large hypotropia, positive forced duction test to elevation and recession, if I can do large recessions, with fixed sutures, that's my first procedure of choice. And I do them until the forced duction test is free. If I see that there is synergistic divergence, I perform for first procedure a lateral rectus periosteal fixation. I don't perform any more resections of the muscles.
So you never do a resection of the muscle in the first sitting, no?
Not now. Not now. I used to do it. But you saw the picture. The muscles, yes, yeah. The antagonist muscles are so thin that they will not give you much.
I think we now request Dr. Fiona Dean to share her presentation, please.
Hello, and thank you for inviting me to speak to everyone out there around the world. That's a fantastic thing to be able to do. And I really enjoy sharing the knowledge that I've gained through looking after this group of patients. So I hope we can learn something together with it. So this is a strategic approach to squint surgery on craniofacial patients, whom I looked after for about 10 years or so. So first of all, as an introduction, I need to tell you what the craniofacial disorders are. They're a group of patients who have a premature fusion of one or more of the calvarial sutures. And they might just be a single suture, which is about 1 in 1,700 to 2,500 live births. Or there's the syndromic forms. These are hereditary and they have extracranial malformations. And this is about 1 in 25,000 patients. So what is the actual effect? Well, when the suture fuses prematurely, then you get abnormalities in the calvarial shape. And this is due to a restriction of growth, which is perpendicular to the fused suture. So, oh, pictures should be coming up. Sorry, these have all come up separately. So if we take, for instance, this one here, this is a sagittal suture synostosis, where the suture going from the anterior to the posterior direction has fused too early, and the skull shape becomes long and boat-like. So you do not get the lateral spread here, particularly in the frontal area on this particular patient, that you should. This next patient, the metopic suture has fused, and this gives a triangular shape to the skull. And in this patient, we have bicoronal suture fusion, and that gives a brachiocephaly. And then we have unicoronal. So we've got one suture fused along here, and this gives a flattening of the forehead on this side and a normalish rim on the other side. So this creates interesting ocular features. So there are many different syndromes now recognized, and I'm not able in this short time to go into details about all of them. I'm going to concentrate on the first 3 of them primarily because they have some interesting ocular features that we can talk about, particularly with reference to their squints. A lot of these genes have been identified, and sometimes the appearance of one may be very similar to the appearance of the other, and it's only when you do the genetics that you actually get a true understanding of what the underlying syndrome is. Those ones are called syndromics, and then if they don't have a particular pattern, then they'd be called non-syndromics, particularly if they're not genetic. So these children have multiple problems. They have problems with their speech and development. This is particularly due to the fact that they get delay in brain development because the calvarium is not big enough. But it also might be because they have abnormal maxillae and abnormal mandibles. The base of the skull effectively is participates in the derangement of shape that they get. They undergo multiple surgeries of many, many different types, and they have episodes of raised intracranial pressure, which in itself causes problems. So as the ophthalmologist, we might be called in quite late because the patient has all these other pressures, life-threatening pressures, pressures on their general development. And the best way to approach them is to be part of a multidisciplinary team where each member of the team understands the role of the other, and that helps in the timing of the intervention, where it's really important for us to preserve the development of the vision. The squint can often be addressed later, but we have to help the team to understand that. And perhaps we're not allowed to operate on the squint at a certain time because something else is going on with the child. And the vision may be compromised by many, many things. And this is a huge list I'm not going to go through all the details of, but some of these things are treatable and some of them are not. So preventable visual loss can certainly be like any other child, the need of glasses because they have a refractive error or anisometropia. These children often are at particular risk of corneal exposure because they have shallowing of the orbits, and they get amblyopia. But in addition, they might have ocular dermoids due to fusions of the sutures and areas where the embryonic planes come together. They might have exophthalmos, hypertelorism. The muscles may be missing. They can have optic atrophy because they've had raised intracranial pressure, ptosis, and then of course strabismus, which is going to be eventually the focus of this talk. So we have a couple of things that we really have to, as pediatric ophthalmologists, concentrate on in these children. And the first is optic nerve swelling from the raised intracranial pressure. Because the sutures fuse early and the brain is still trying to grow, there's no room in the calvarium for the growing brain. And as a consequence, the intraocular pressure rises, giving, of course, the typical signs of papilledema. And if this is left, then these children end up with optic atrophy, as well as the many other developmental issues. The other problem for acute sight-threatening disease is the fact that they have shallow orbits and they get corneal exposure. Quite often their eyelids won't close completely, or even sometimes the eyelid gets caught behind the globe, which is so proptosed that there is no room in the orbit for the globe itself. So we have the preventable visual loss, and if we were to look at those groups that I was explaining earlier on, aperts, pfeiffers, cruzons, and unicoronals, you can see there's quite a significant amount of astigmatism, with about half of the aperts having astigmatism, about half of pfeiffers, a quarter of the cruzons, and about 18% of unicoronals. So this is quite an important part, is getting these children into glasses. However, they have an abnormal head shape and often need hearing aids as well. Now, pediatric ophthalmologists are well aware of the difficulty in getting children to wear glasses when they have hearing aids at the same time. But when they have an abnormal head shape, trying to get glasses with astigmatic correction in at the right angle on an abnormal shaped face is extremely challenging. So we can finally move on to strabismus in these patients. And again, just looking at these three groups, you can see that practically all of the patients in aperts will have a squint, with a very small percentage, 5% in this group, that didn't. And some of them can be ESO in one direction and EXO in another. So 6 or 14% is not insignificant. Those, excuse me, are particularly tricky to sort out. It's much easier if you've got one ESO or one EXO. And we have a similar kind of pattern with cruzons and a similar type of pattern with the pfeiffers. So we're only 20% of those patients didn't have a squint at all. So it's a significant need of input from a strabismologist for these patients. But not all the children who present will actually need squint surgery. Some of them may be binocular in the primary position, as this child is, but they might have eyes that are not aligned in all other directions of gaze. And we need to remember that keeping the primary position as the most important area, that and down gaze, has to be our remit. And although the parents may be quite concerned about the appearance of the eyes in lateral and up and down gaze, we need to sometimes emphasize to them that primary position and down gaze are the most important, and perhaps the child may get this disrupted if we do a squint repair on them. So we have to have a strategy for approaching these patients. We have to understand the reason why they might squint, as this guides our management. And we have to be prepared with investigations before the surgery, because this prevents some nasty surprises, which unfortunately I have had in the past. We have to understand the syndromic abnormalities. They each have their nuances into how each suture the shape of the orbit. We have to treat the underlying visual problems, work with the rest of the team to investigate the orbits and muscles. And this would involve CT scanning and MRI scanning. So many of these children will have already had a CT scan because they want to look to see whether there's suture synostosis. But an MRI scan may not have happened or may not have incorporated the orbits. And we need to see where these muscles are. And indeed, we need to see if the muscles are present at all, because some of these patients will be missing muscles. We also may need to consider squint surgery during the same general anesthetic as another procedure that the child's undergoing. And it's our job to help the multidisciplinary team understand the importance of binocularity and the fact that we might need to operate on some of the squints early in order to either attain that or retain it. So these muscles themselves may be abnormal and the orbits may be abnormal. They do not subtend the globe at normal angles, and they give a wide variation of pattern, A pattern, V pattern, X pattern. As I said before, the muscles themselves might be missing, and you need to know whether they're missing. Otherwise, you start your surgery expecting to transpose a lateral rectus and find, guess what, the lateral rectus isn't there. And the orbits may be two different shapes and sizes, and that can actually lead to a mechanical advantage imbalance between the two eyes. They may be very shallow and they may be far apart, so giving the patient hypertelorism, which is more likely to lend to exotropia. So here's an example of a patient with plagiocephaly. That means that they've had a unicoronal synostosis. So the synostosis is here, and the corresponding shortening of the orbit is here. And you can see this is the base of the skull, and the base of the skull is not normal. The orbital shape on, this is the right actually, and this is the left. So the orbital shape here is tilted outwards, and the distance between the front and the back of the orbit along the nasal wall is actually shorter on this side than the other. You can see the right side suture synostosis here. So this is a diagrammatic example of a patient with plagiocephaly where the orbital wall is shorter on this side. So this is to represent the superior oblique and it's coming to the trochlea here, and then it's turning through the angle. And as you can see on the other side, this subtends a normal angle, B being the superior oblique on this side, and A being the inferior oblique. But when you've got the shortened upper wall, your superior oblique subtends a different angle to that subtended by the inferior oblique. So they no longer balance each other out. And in addition to that, by the fact that it's, by the fact that it's coming at this angle, it causes more intorsion than it does depression. So it changes the balance compared to the other side, and also it's out of balance compared to the inferior oblique. So this is an example shown in a paper published in the Journal of Binocular Vision and Ocular Motility. This child is a unicoronal synostosis, excuse me, and this child is unable to elevate very well with this left eye here, and the superior oblique is also weakened. So they actually treated this patient bilaterally with bilateral superior oblique tucks in order to try and strengthen the superior oblique strength bilaterally. And these sort of treatment, you need to take very much on a case-by-case basis. So bilateral was appropriate in this case, but in the previous patient that I showed you an example of, they only doing a unilateral superior oblique tuck would have been appropriate. So this patient has Apert syndrome. And as you can see, the orbits are a very different shape to usual. And what I want to bring your attention to is the fact that this actually is a tilted orbit. So the medial canthus here is much higher than the lateral canthus. And we've got the same on the other side. And the normal is that your lateral canthus is a couple of millimeters higher than your medial canthus. And what this indicates is that the whole of the so if we look at this diagram here, the medial rectus, which is normally pulling in this direction, this is a demonstration of the left eye, the medial rectus is actually an elevator as well as an adductor here. And the lateral rectus is a depressor as well as moving the eye laterally. So this child will end up with a seesaw movement. Now, this doesn't just occur in patients with craniosynostosis. I see this quite often in my clinic with patients who would be considered as normal. And if you see this seesaw movement from left to right, then this is something you should be considering, and look very closely to see whether the lateral canthus is below the level of the medial canthus, because the lateral canthus is at the suture of the temporal bone and the maxillary bone. That's where it engages, and therefore if the orbit is an abnormal shape, the lateral canthus will tell you that. So here is a child who has, this upper one here is perhaps not quite so clear as the lower one. This child has the seesaw movement. You particularly see it in this one here, where the eye rises upwards and this eye goes downwards. So how do you know that this is not just inferior oblique overaction? And it is about looking for the lateral rectus depressing the eye as the eye moves outwards, as well as seeing the eye moving medially elevating. And then you get a swap over. And the swap over is much more obvious in this patient here, where it's elevating here and depressing here. And on the other side, we've got elevation and depression. So in these patients, if you think, oh, this is an inferior oblique overaction, I'll go and do that surgery, you'll find it won't work because it's not really the underlying problem. And therefore you actually need to consider moving the horizontal recti up or down, depending on whether they may have predominantly an A or a V pattern. Normally it would be V, but not always. So as I mentioned before, you might have patients who have missing muscles as, sorry, I apologize, these pictures are rather dark, but this young man could not abduct this left eye at all. And that's because the lateral rectus was missing completely. And therefore, if you hadn't done your MRI scan to look for that muscle, then you'll go in there and go, oh, now what do I do? And it's much more comfortable if you've actually been able to plan this situation well ahead of time by working out that the muscle's missing, and you may have to transpose a superior or inferior rectus around with the foster suture together, or move them completely around to the position of the lateral rectus, or split them. There are many ways of doing that. But without the preparation, then you're not going to know that that kind of thing is possible or necessary. So other things we may need to consider are the lids. Many of these children, because they have a shallow orbit, will not actually be able to use the lateral gaze because they've had to have a tarsorrhaphy. And therefore, if the primary position is not too bad, then the lateral gazes may become less of a cosmetic issue once the tarsorrhaphy is done. And this is a good example where this child has an extremely shallow orbit. As you can see, these eyes have actually had a tarsorrhaphy performed laterally. And if that had not occurred, this eyelid would in fact be way up, almost behind the equator or behind the globe. So these patients don't usually have the proper support, bony support that you require to keep the globe well protected, and the tarsorrhaphy becomes necessary. You might even have to drop the lid as possible, but they have a skin shortage as well, which makes that even more difficult. So as you can see, although this child is a little bit exotropic, this is not particularly relevant at this time in this child's life, and looking lateral is not really a problem because nobody's going to see the fact that they're exotropic when they do so. So just to reiterate, the orbits can be shallow, they can be asymmetric, longer or shorter. They might have a frontal prominence. So the plagiocephaly patients who have a flattened orbit on one side and a normal orbit on the other side become astigmatic on the normal side, a bit like ptosis gives you astigmatism. One orbit that's more proud on the frontal bone than the other can also do the same thing. The orbits can be tilted or extorted, and the patients can have a wide IPD and hypertiny. So it's important to understand what kind of squint you've got, and you have to expect the unexpected, which is very similar to Dr. Molinari's talk about these patients where you get the unpredictable results. Make sure that you're not looking after a case of a missing muscle. understand the shape of the orbits, and that's why it's nice to have the MRI scan and the CT scan. And are you seeing an overaction on one side because there's a difference in mechanical advantage due to length and angle that the muscle might subtend to that eye? And just be mindful of the fact that sometimes there may be mimicry of certain muscles looking like they're overactions of others because of the tilting of the orbits. Timing of surgery, primarily we would like to preserve binocular function, and that would be a reason to operate early. But again, you want to try and consider whether you can piggyback that onto another surgery that this child's undergoing, because you want to reduce the number of general anesthetic episodes and the number of admissions these children have. The craniofacial surgery, the change in the calvarium, does not affect the squint. We used to think it did, but we know now it doesn't, and that's because the key landmarks within the orbit are not changed. The operations don't change the position, for instance, of the trochlea. And the strabismus surgery, unfortunately, to a strabismus surgeon, has to take a lower place in line of many of the other surgeries, which are key to the development of the child. So just to re-show this slide, because it's the most important really, you need to understand the reason for the squint. That will tell you what the management is. Be prepared by doing the appropriate investigations. Understand the nuances of each of these syndromes so that you know what you're most likely to come across, and consider, as part of a multidisciplinary team, timing your anesthetic need with that of another procedure. Thank you.
Thank you, Dr. Fiona Dean. It was a very nice presentation. And the questions, before I take the questions, I have a few. So most of these children, I find that they have a large V pattern. You know, most of them come with a large V pattern. So
That's
what is the, yeah, like sometimes it's like a 40 V, and you know, like, so sometimes even doing an inferior oblique and shifting the medial rectus also, suppose if it's a lateral rectus, so it was a V exo, find that still there is some amount of residual. So what do you means, anything specific like which we have missed or something?
No, I think that you are working with an orbit that's tilted, and this creates the V. So if we think about the slide I showed you where the medial rectus was working upwards, the superior rectus is working upwards and outwards. So the superior rectus is also creating the V, and the inferior rectus is working downwards and inwards, and is also, so everything is pushing towards a V pattern. So if you were to treat your inferior obliques and move your lateral recti up and your medial recti down, and you still had a very big V, then the next thing you'd have to consider would be to move your verticals across in order to decrease the V further. Now, in my experience, that's never been really necessary. Usually doing all those other things is enough. And I think you can get to a point where you could keep going forever with them, really, and that may not be appropriate. Just because we can doesn't mean we should.
So I think the importance is doing the imaging. I think imaging is a very important.
Yes, it is.
Has to be done in most of these cases because there could be surprises. Is the fundus torsion useful in these patients to differentiate from inferior oblique hyperfunction?
Yes, I think it's just part of a puzzle. I don't think you can ever take things in isolation, but it is helpful to know that the fundus is also tilted. But it's not always there. So sometimes you might think, oh, this patient ought to have a fundus that's tilted, and guess what? It isn't. So not everything necessarily follows what you think it should. And sometimes I've seen fundi tilted, extorted, and the extraocular movement pattern hasn't fitted with that.
Have you had that you have done the procedure and there has been some problem for the cornea or anything, like there has been increased exposure? Because they do say that inferior oblique anterior transposition should not be done. Is it? Have you seen? Because instead of recession, you should mainly an inferior oblique recession and not do an anterior transposition. There's no, I don't know, it mentioned in one of the books, so I just thought
I
that
haven't
could
actually
have
seen that as a particular problem, mainly because their corneal exposure is just such a significant issue that they're better off having the frontal face brought forward. That's really what they need. They need the orbits deepening rather than us doing something with the eyes. They need the orbits deepening. That is going to sort the problem out. The problem is that you do not want to advance the maxillae until the secondary teeth are through. And this is why the timing is so important. However, you can't leave the globe exposed until they're 16. So you have to sometimes do the maxillary surgery earlier than would be the ideal timing for the teeth.
There's a question that if there is a case of post-operative diplopia, if patient is not accepting monocular occlusion or fogging, what to do next? You normally do get fusion in these patients if they're operated early.
Yes, you can do. And if they don't, then you've got to consider whether or not they go for occlusion or whether you might be able to give them a contact lens. Worst case scenario, you might have to give them a occlusive intraocular lens. But usually they're small enough children that they've adapted and they end up suppressing in the areas where they're not going to be seeing with the eyes aligned.
I will be talking on another topic, which is actually very dear to me also, which is cerebral visual impairment and strabismus in children with cerebral visual impairment. So any child with subnormal vision, you need to do a detailed ophthalmic examination. You need to check whether it is ocular disease or an abnormal anterior visual pathway. Then it is not CVI. But you get a normal eye examination and a disproportionately subnormal vision, and we need to suspect it is a CVI. We need to ask for a proper birth history, neurological evaluation, and neuroimaging if it is important. So we should suspect CVI in all children with unexplained bilaterally decreased vision. So what exactly is CVI? It is basically a deficiency in the function of vision. If something is wrong with the visual pathways or processing centers in the brain, specifically those posterior to the lateral geniculate body. So the eyes work fine, but the brain does not consistently understand or interpret what the eyes see. So basically, we know that now vision is a neural association. We have the dorsal stream and the ventral stream. The dorsal stream connects the occipital area with the posterior parietal cortex, and that tells us it is where. And the ventral stream, it connects the occipital and temporal lobe and tells us what. So these are the many ocular manifestations which we see in these children. So what we see is that you can see here that the child is not fixing or following a light and it's not appropriate for the particular age. So there is no eye contact. So the parents come over, the child is squinting. There is mainly the wandering eye movements. There is no contact. And they come to you with this, they say it is squint. It's not squint, basically not even fixing and following in the light. If there's any decreased contrast sensitivity, if you find that in these children, most of these children have decreased contrast, that's the important test to check whether we need to do some more rehabilitation. We also need to check their fields because some of them have inferior field defects. And these are simple tests where we can do the fields and find out if there are any field defects, and that could help us in our management. Now, this is a child where we find that there is very poor visual latency, like the visual latency is very poor. He's not reaching out to objects. And so the cataract has been done, but still the child has delayed milestones and is not really looking at any object. There's a small esotropia, but the child is not, is feeling confused in a clutter. Or you can have like this, where there is a gaze preference and the child does not look towards the left side, but only towards the right side. So these are children we need to pick up in the clinic because these are children who may come to you with small forms of strabismus and their parents say that they're slow learners. And then we find the simple test like a SLEA, this we have made it with the help of a carpenter, where we can see that the children have visual conceptual skills are absent. And these children need to be taken care of. So now sometimes the therapist or the psychologist may refer to you that these children are under us with therapy, but please help us. Maybe there's also an associated strabismus and you need to take care of this too. And of course, it will help. The strabismus surgery also helps in this regard. So The other test which you could do is a Lear mailbox. So this is another test. Now you can see that this child, it clearly tells you where the orientation of the slot is. You ask them where the orientation is, and then the child puts the card into the particular correct slot. But see this child with CVI having a small amount of esotropia with a brain damage and not able to do, and there's a severe eye-hand coordination problem. There's sparse pointing. And this child could be helped with therapy and maybe even your strabismus surgery. So there could be, so the other things we have to look for is the optic nerve, whether there is a optic nerve hypoplasia or a pseudoclocomatous disc. So the strabismus is seen in as high as 73% in patients with CVI. It may range in cerebral palsy from 19% to 50%. So esotropia is most common. Then we find there's exotropia and specific traits, like we find that there's angle variability and shifting patterns. So this was published that an important cause of visual and ocular motility dysfunction in children is because of periventricular leukomagnesia. That is why it is important for us to ask for the birth history, and if there is any delayed milestones, we may find them with latent nystagmus, dissociative vertical deviation, so any of the squints which could be present. In our study, which we published in the Indian Journal of Pediatrics, we found that our exotropia was seen in more commonly than esotropia, and also nystagmus was present. And we had a large number of children with exotropia and esotropia, and the range was very large. And there was also present with DVD. So another paper which we published in Journal of Pediatric Ophthalmology and Strabismus in 2019 also revealed that we had 67.04% of children with strabismus, out of which they had variable angles, which are seen in few patients, and some of them are intermittent. And we could only measure them in around a few number of children. Most of the time, the children are very uncooperative. So like this child who has come to us at 5 years of age and with the concerns like poor vision, squinting both eyes, maintaining a head posture, very poor performance in school. Birth history, when we found that it was a preterm baby, did not cry at birth. MRI was done, was diagnosed as HIE stage 2, but referred to an ophthalmologist, and they said that to wait for some more time. The child fell down from the stairs because of the problems, and he suffered another right hemiplegia and facial palsy. So then we planned a squint surgery at the age of 6 years with vision of 624. So why are we so scared in operating these children? Because are they very not cooperative for the measurements? Do children with neurological problems have different motor outcomes, or do they achieve binocular fusion? So most of them, that this was a paper published that you need to observe the children with poor visual behavior and with unstable deviation or shifting pattern. But if they develop a constant angle, we should go ahead and we should operate. At least take 4 stable measurements. Of course, only 16% showed spontaneous resolution. So like this child who we had a esotropia, a premature baby with delayed milestones, with a stable angle deviation of 45 prism base out, and he was operated for strabismus. Now, it is not important. It is important not only to do the strabismus surgery, but also to continue with the therapies post-surgery. And this is what the parents tell us, that before the surgery, the child was not able to write in a line, or the handwriting was not very good. And after the surgery, the handwriting improved. It was written in a line. And this is what the therapist tells us, that please do the surgery, because we do find an improvement in the hand-eye coordination. So what are the long-term results in these children? The paper said that there are less predictable surgical results, there are overcorrections, and some of them say that there are satisfactory results with additional procedures. So we did a study comparing it with normal children. Of course, our data was very small. We just had 26 children in our data, and we found that most of them were children with birth asphyxia and cerebral palsy. They had a pre-op deviation around more than 40 prisms, and they had a 61.23% success rate. And there's another paper published from Shankar Netrala, which also said they had an outcome of 60% good outcome in 60% of patients. And so few of them, what we found was that residual esotropia, since we are undercorrecting them, some of them landed up with continuous residual esotropia. So we needed to add on another surgery, but after another surgery, they did do well. And we found that few patients developed consecutive exotropia. But sensory, like there was a paper published in IOVS, which stated that restoration of binocular alignment and a degree of fusion is a realistic goal. And I do find that we should operate because, of course, we do not get the amount of stereopsis which we would ask for, but definitely there is an improvement in the functional vision, all the functional vision impairment problems. So one thing which you have to be careful of, they do land up with consecutive exotropias. And so these are the few papers which have been published that we need to, because there's an exaggerated effect of the bimedial recessions done in them, in development delayed children, we need to do a 30% undercorrection. But sometimes when we leave behind a 30% undercorrection, they do have some amount of esotropia left. So we need to continue with patching, maybe add a little bit of hypermetropic glasses and treat them. So this is when you have a consecutive exotropia, you need to do a medial rectus advancement and maybe a little amount of lateral rectus recession. So now this was referred by a psychologist saying that this child was not improving, 618, the child was not able to write properly, there was an attention disorder, MRI showed HIE, but they were suspecting autism. And he said that as an exotropia, why don't you go ahead and do the surgery? I said that, will there be a good result after the surgery? I operated, there was a motor stability. And what he did was, the psychologist, he said that before surgery and after surgery, he found a few parameters improving, like a social quotient with Ford. He found that communication, socializing, then he found that even the borderline developmental delay tests which are done improved with cognitive and other communication skills improving. And also the other like attention problems were also improving. So he has convinced me that we need to go and operate them much earlier. So in cases with sometimes presenting with dissociative vertical deviations along with exotropia and being slow learners and not performing well in school, it is important to get an MRI, and do find that these are children who have been missed as HIE, and they have the squint has progressed, and once they've gained fixation of fusion, the parents have started noticing that the squint is more visible, and then we may have to do the surgery. So this is simple exotropia surgery with a superior rectus recession surgery was done for the exotropia with DVD. So another boy with a 14-year-old, he was saying that he could not draw his geometric figures, like he was not able to do any circles or any squares, and he found so much of problem because he had developmental delay. The therapists were working on his perceptual skills. They tried brain gym activities, modification in his writing, but they found that always the eye used to go up, or there was a exo deviation, and they convinced me that please go ahead with this surgery. And after doing the surgery, I found that the child the boy himself says that now I can do the geometric figure. He's so happy saying that now for the first time I could do the geometrical figures. But in this child, after I operated, I found that there was still residual dissociative vertical deviation. I did an asymmetric deviation thinking that the left eye deviation, DVD was more than the right eye. But I found after surgery, there was a residual DVD now in the right eye. I went ahead and did a right eye application because already I touched the two recti. And this is what I would like to discuss. I found that the right eye was slightly smaller now, and there was limitation in elevation. So I wanted to ask, is this seen routinely, or because I don't do too much of plications, but because I wanted to prevent an anterior segment ischemia, I did a plication on his inferior rectus, and I found that this is just the 3rd week of surgery, but it was mild limitation of upgaze was there. So there are mixed deviations in these cases. So we need to look at all type of squints are there. Like this is a child with esotropia, with superior oblique palsy, head tilt, and he could not walk. And we are helping the child by doing the surgery, and the child can get the parents do come that they improve better. So therefore we say that it represents a spectrum of disability, and they get significant benefit from specific intervention for ophthalmological abnormalities. But of course, we need multidisciplinary services. Thank you.
That was a very nice presentation, Dr. Suma. I was wondering, because I have seen the same observation of improvement in all other psychomotor areas after operating on the strabismus. And we also have done a paper on this, or an investigation. We didn't publish it. But the problem is that sometimes I have seen cases, and you probably have too, of patients that are, the angle of strabismus is so variable that they start with an esotropia and you keep observing them. And then in the end, they end up being exotropes, without having done anything. So I think you have to put in a balance. If the angle is very variable, maybe it's better to observe in some cases to see in the end what happens. The other question I had is if you you said that you usually undercorrect these patients, so you use other numbers for recessions, and you mainly do recessions, not resections or plications in general.
Yes.
What I do when I have esotropic patients with very variable angle, what I have been using in the last decades is a small recession together with a Faden procedure. And I have seen that by doing this, I have had less incidence of consecutive exotropia.
Yes. Yeah. So I wanted to ask about the plication. So will this improve over a period of time? Because it's just 3 weeks post-operative, the eye going up.
Yes, it's like a Brown syndrome. It's like a iatrogenic Brown. When you do a plication of the superior, when attacking of the superior oblique tendon, you have a Brown syndrome at the beginning, and this gets better. The same thing I have seen it with plication of inferior recti. Although you have to be careful when you plicate the muscle, after doing the plication, try to the force duction test, and you have to notice that the force duction is not so positive.
Okay, fine. Dr. Fiona, any comments and are there any questions?
I certainly have an experience with these patients who have cerebral palsy going from ESO to EXO or EXO to ESO, and they are quite unpredictable. For many years now, I've treated what appears to be congenital esotropia with botulinum toxin the earliest I possibly can. So from 6 or 7 months up to a year old. And some of them we don't know have cerebral palsy at that point. But when I did audit these, we found that the ones that were having less predictable outcomes with Botox were also those with CVI or cerebral palsy. As far as Andrea was talking about delaying or perhaps just observing some of these patients, let's wait until it's really important to the child, because this child is on a lifetime pathway of needing multiple surgery because the eye goes in, it goes out, it goes in, it goes out. Let's do it when it's really needed. And that then decreases the number of surgeries. But say they want a job and they're going to go for an interview, that's the kind of time they need it. They're going to get married, or they're looking, for a relationship or something like that. These are key times in someone's life where their eyes might really matter to them. And that's probably a better time to operate on those than just jump in and do it because it's there, when you're going to end up doing many surgeries down the line of the same child.
I agree, totally agree with Fiona. And there is a question in the chat box, in the Q&A box for you, Dr. Suma, on how do you explore visual fields in CVI
I showed the
patients?
video. I showed the video how you can use a white board, because in these children it's very difficult to put them into any machine. So you just take a white board and you just show toys. I mean, I showed the video that where you can just pop up toys in the upper field, in the lower field, on the side. This is just like a gross confrontation test. So whenever you pop up otherwise you have the Leah wand. Leah has come up with the field test where you can use it as a Leah wand is there, but it's pretty expensive. So and it's not like you can come to know in these patients just by most of them have inferior field defects. So we just have to tell the therapist that they need to be rehabilitated, because sometimes they keep falling down and the parents say that they're bumping into objects. So otherwise you could do a simple test where I just show the video where you have whiteboard and just pop up the objects on all the sides like a confrontation test and see where the child looks. The child does not look at the object.
And this is also why the behavior of these children improve, or one of the reasons why the behavior of these children improve after surgery in isotropic patients, because the visual field it's larger, and yeah, and they can be more receptive to stimulus, external stimulus.
How do we address contrast sensitivity in these patients? So we use the contrast the HIDE test, because they are not going to be really cooperative for the Pelly-Robson chart. So I showed the video. I think that's why I showed the video particularly about how we do the contrast. It is with the LIA, that is these contrast HIDE test. It is available. And it is from 5%, 10%, 25%, and 50%, and it tells you how much there is a loss. So normally it is like we all have around 5%, that's normal. So then in children, sometimes they have 25, in these children, they'll have a 25%. So then you need to tell the parents, or you need to tell the therapist that they do not have much contrast sensitivity. And then the therapist, what they do is they tell the parents that maybe they need to put a lot of dark lipstick or something to increase the a contrast of their faces. So that's why the contrast sensitivity is very important to do in these children. Okay, I think that's the end of the webinar. I think it was very nice. Thank you, Dr. Andrea and Dr. Fiona Dean. It has always been a pleasure to to discuss cases, and I think Dr. Fiona Dean also is there in the grand rounds, and Dr. Andrea also. And I hope we continue to teach more, and I also learn the process. Thank you so much.